let's get going, and thank you all for joining us this morning. And we had noted this down as a 30-minute session because obviously we wanted just to help those folk that are in the ET3 program, that are working their way through the NOFO, and obviously are puzzling and scratching their heads at where do we get this information from, how can we find out what we need to know. And that's the reason that we're here this morning, in order to help you get some answers that you need for your NOFO completion. So that's good. So on the panel today, I'm here as the kind of master of ceremonies. As Todd said, we've also got Mike Taigman in the room, and we'll be conducting this CTM style, Conversations That Matter style. So if you have a point to make, then Mike is going to harvest the questions. As I will tell you in a second, the good news is we're available to wait to be here for the full hour, and so we can actually really drill into detailed questions at the end of the formal session. I'd like to introduce some folk you already know. Todd Stout, of course, is here. Also, Dr. Conrad Fibers, the Medical Director of Priority Solutions Incorporated, and also Elaine Messerli-Kelly from EMK-Consultants, and she's been doing a lot of work with our friends up at REMSA, and she'll tell us a bit more about that in a minute. We're conducting this presentation Marquis of Queensberry style, so here are the rules. This session is being recorded. We have a lawyer on the line, I can see, and under California law, I have to tell you that we are recording you. If you don't consent, then by all means hit the stop, thank you and goodbye button, but we hope you'll stay with us. There's a chat box, which also we'd like you to just introduce yourself. Who are you? Where are you from? And I'm sure Mike will love to see that and will respond. Also use the chat box to ask any questions. As I said, Mike is going to be harvesting those questions for the Q&A at the end. And as I said, we're staying on for a further 30 minutes once we finish the formal presentation to answer any detailed questions that you may have. And so we're looking forward to that as well. So in terms of what we're going to cover in the next 30 minutes, we're going to talk about ECNS, its eligibility and its time frame. We're also going to have a little bit of a history and how do we get here session from Elaine as well. We're going to talk about FirstWatch and ET3 from Todd, the REMSA and ConFire experience. Getting onto the RFP, of course, for those that aren't familiar with RFPs, of course, the prize is in scoring as many points as you can, and we're going to talk about the scoring. And then we're going to talk about the template, and we've gone through the whole NOFO, and we've identified those things that are relevant to the ECNS, to FirstWatch, to data, to quality, and we've extracted and answered and provided some solutions there, and we'll talk about that. Next step, further resources, and then we'll get into the Q&A probably in the second half of this session, so the second half an hour. In terms of timeline, I'm sure if you're involved in the NOFO process, if you're enrolled in ET3, you are painfully aware of these timelines. Obviously, we are now running fast up to the deadline of May the 11th for the NOFO submission, and obviously the timelines that roll out from that. And Conrad is also going to talk a little bit later on about some of the sort of detailed timeline as well within that. And obviously we're aware of the award and also aware of the number of awardees that will come along. So hopefully you will all be in those 40 awardees, and we hope so. So we understand that this NOFO is for the medical triage line, and its origins come back to the Sterling work done at REMSA. And Elaine, do you want to pick up the story from the beginning, really, and sort of just bring us into it?
Sure. Good morning. I'm Elaine Messerli-Kelly, and I was hired at REMSA, which is a private non-for-profit ambulance company in Reno, Nevada, in 2012, after REMSA had been awarded a $10 million grant through the Center for Medicare and Medicaid Innovation Center. So with our goal of decreasing cost in our community. So one of the things that we did was we established a nurse triage center by partnering with Priority Solutions and their evidence-based protocols. We took 911 callers that would have gone directly to an ambulance response to the emergency room, and we developed our nurse triage where we could then get to a recommended care level and get them to a community resource within Reno, Nevada. and developed a directory of services so 911 callers could potentially either stay home with evidence-based self-care instructions, get care at an urgent care clinic, and even get set up with a telehealth visit. The nurse helpline and nurse triage that we did in Reno, Nevada, produced the highest cost savings throughout the 4 years of that grant. And with the data collected with the help of FirstWatch, then CMMI came up with this ET3 model to really kind of roll out the proof of concept that we can save money in communities. About 3 years ago, I developed my own consulting company, and I'm still working with REMSA. Adam Hines, who I think is on the call, has taken over that whole project. And one of the new things that we've done really recently is a new innovation with San Bernardino County in California. And San Bernardino County during COVID wanted to stand up a nurse triage system and developed a relationship with both Priority Solutions and FirstWatch, and I wanted to get that up and going really quickly. So we developed a process where their ACE Center for EMD was able to transfer callers, low acuity callers, over to the REMSA ACE accredited nurse helpline and get those callers out of the 911 system while they set up their own nurse helpline. And I think Leslie Parham from San Bernardino County is on the line as well.
Thank you for that. And I'm going to move on to Todd just to talk about the sort of FirstWatch part in it. And Todd's got a few slides, so advance the slides. Todd, with the time-honored phrase, next slide, please. And you are on mute.
Oh gosh, I was even hilarious for a minute there, so inadvertently hilarious. Okay, well, thank you very much for your help with that. So FirstWatch has been monitoring public safety data, as a lot of you know. I see a lot of friends online with us now. Since 1999, REMSA was actually our third customer agency that we ever monitored for a long time. And in our case with REMSA, we're very proud to be included in their CMS Medicare proposal for the grant process that they won from the beginning. So it was very nice to be a part of helping gather that data. So we've been involved with all of the REMSA's work, which has really translated into a lot of what we see, as most people know, in all of the ET3 projects, including this one. So we're very, very fortunate. We've been around about 22 years. Our customers cover about 48% of the population of the United States. So a lot of you are our customers and partners and friends. We get a new record about every 0.6 seconds and are really just proud to do that. Next slide, please. By the way, you don't need to go back, but in addition to REMSA, we're with a lot of other folks, including MedStar and Northwell on a lot of community paramedic type work.
Todd, can I just throw a note in there before you go on? Just to mention, we are recording this, and one of the good reasons we're doing this is that we have some apologies this morning because, as some of you will appreciate, there are a number of citywide briefings going on around the country in the event of civil disorder from obviously the verdict that we're expecting. So we do have some apologies, and this is why we're recording it. Sorry, Todd.
Yep. Oh, no, thanks very much. I appreciate it. The real world does continue to intrude upon our lives with COVID and everything else. So the way our system works typically, and it depends upon the system, but it works for most CAD systems and with ProQA and with LowCode, the nurse healthline, the nurse triage system, and then a lot of the electronic patient care records, the data is pushed to us, but we get the data in. Everything that happens in FirstWatch happens on our servers, so you don't have a bunch of things. And we've been sort of cloud before people in EMS called it cloud. We'll send out alerts. And a lot of the answers that you're going to see, or if you go forward with us that you're going to see, are really a combination of normal FirstWatch processes and systems really put together to meet originally REMSA's needs and now ET3. Go ahead, please. In REMSA's case, just as a really good example, we are monitoring and have over time 5 different data sources. Their CAD system, their ProQA, their LowCode nurse triage, their RescueNet PCR, and they may have changed since this slide. I can't remember, and I apologize. And then also they have a community paramedic program. We tie all that data together, which is really what allows us to provide the answers for you in looking at different things. So in this particular proposal, it counts on having CAD data, ProQA data, and LowCode data, because there's a lot of work to ensure that patients are not only taken care of, but that there are not problems after the fact with patients that are handled by Nurse Healthline. Thank you, Rob.
Thank you. I'm going to hand over to Dr. Fivers now to talk about a little bit about ECNS.
Good morning, good afternoon to those folks on the East Coast. Thank you, Rob. I'm just going to talk a little bit about ECNS eligibility. Currently, there's 4 scenarios. There's those existing MPDS users that have an ACE accreditation, and they're also using ECNS. There's those MPDS users that are ACE that's not currently using ECNS, and there's existing MPDS users that are not ACE, and then there's agencies that's not using MPDS or ECNS. If you can move to the next slide for me. So the detailed timeline that's available on the CMS ET3 website clearly lays out the timing for this implementation. What's interesting about this is that there's a full year available from September 10th, 2021 to September 9th, 2022 to actually do the implementation, to establish your current infrastructure, to ensure that the software systems are implemented, that interfaces are being developed, that nurses are being appointed and trained, and as well as training for your current EMDs as well in the whole process. What that effectively means is that individuals or agencies that are using MPDS but that does not have a current ACE designation have almost more than a full year, considering if you start working towards that goal right now, to achieve an ACE designation. And obviously, the international academies will assist with that, the program they call their Race to ACE, to assist those agencies that's not currently ACE to become ACE. So why is it important to have an accredited center of excellence designation when you want to use ECNS? And the answer is fairly simple. It's all about safety. We have to ensure that when we start a medical triage line, that all those safety tick boxes are checked. And one of them is we want to make sure that the origin of those low acuity calls are in fact, they are what they say, they are low acuity calls, that when they get sent across to the nurse on the nurse medical triage line, that there's no delay in response to those calls that's considered low acuity, but in fact is harboring something more serious. So that's the first step. Then there's a few other items that's really important to put some focus on. Over the 20 years we've been dabbling in this medicine, we've learned quite a lot. First of all, your protocols. The protocols must be research-based, evidence-based, well-trialed and tested protocols. At the International Academies of Emergency Dispatch, we've got an ECNS Council of Standards, which looks at regular proposals for change that's been submitted from many countries on 4 continents that's using the application over the 2 decades. And within this Council of Standards, we evaluate that proposal for change on the balance of evidence available, and that change makes it into our protocol. The protocol is used internationally, so a change that we effect here in North America will also impact the agency in Australia and vice versa. So what we learn from international agencies, we apply locally as well. And then QI, quality assurance, quality improvement is of utmost importance. Having a system where you can listen to these calls, you can measure the quality against a set of performance standards, and objectively evaluate the work your nurses is doing, and then also give feedback to these nurses. to ensure the best outcome for the patients. Another aspect that's important as part of this application is optional items. How can we facilitate the process of alternative responses on the patient's behalf? For example, booking them in with appointments with their primary care provider, organizing an alternative transportation mode for them, for example, Lyft or Uber. And also very important is facilitating warm handoffs, for example, to telemedicine agencies, a video call with a doc in a box type exercise. These are valuable items that facilitate patient care. And then important is also having those interfaces set up, and we have a whole year to get all of those important interfaces established. The interface between your clinical decision software system, in ECNS case LowCode, have a very solid bidirectional interface with your CAD provider, your CAD, your existing CAD, to ensure that there's those safety mechanisms for checks and balances. If a nurse declare an emergency, there's an automated update back to your CAD to arrange for dispatch of a vehicle. That's just in a nutshell. Thanks, Rob.
Thank you, indeed. So moving on, obviously you've all got the 78-page NOFO, you've all gone through it. And for those that don't have much experience in completing RFPs, one of the first things that the eye always drifts to is how you win the prize, how you actually achieve getting granted, in this case, the money in order to create the system. And so the eye always drifts to the amount of points that you can score from each of those sections. In other words, the detail that you enter into the narrative and into the return that you provide, of course, affects how lucky you'll be, in fact. And so we spent some considerable time going through the NOFO and identifying where the points are, and of course identifying where the answers are that you may well like to have contributed from the likes of FirstWatch and from Priority as well. And so what we've produced, and the way that we will issue this, is that when this particular session is over this afternoon, we're going to send a constant contact email out, reissuing some of the contact details for the people that you've seen today. And from there, we can then actually give you the full response set. What we've done there is we've created a template where we have gone through the NOFO. We have identified where the questions and therefore the answers are required for your submission, and we've put in some generic responses and some generic answers that will help you develop your own answers. And the way that we've done it, as you will see from the template, we've created a template, and what we've done is we've referenced it against the NOFO, the page number and the section number in which that question that may or may not be relevant, that will be relevant to the products that you're seeing here today apply to. So in other words, when you start to see the template, you can work out quickly how to cross-reference it against the main NOFO document. And so what we've done is we went through and actually highlighted the question that is relevant to the nurse triage, secondary triage, QA/QI, FirstWatch products, and then identified the question, and then also identified the value of it in terms of points, and therefore giving a comprehensive answer is going to score the points that you need in order to be successful in the RFP. And so this is an example of the template, and then we've started to put, or we've completed putting answers in against the questions, and we have something like a 25-page document now with the questions that of course can be tailored to your organization, but of course they are referencing the products that you see today. And so this is an example of a priority response answer to one particular question. As you can see, you've got quite a comprehensive answer there that you can then, as we've been saying for a while now, you can then cut and paste out from this document into your RFP response. Similarly, we have an answer, a FirstWatch answer, and we've quite simply color-coded it in the document, so you can see that green is a priority answer, and orange is a FirstWatch response. sorry, I've done the wrong way around. Sorry, I'll do it again. So this is a FirstWatch and this is a priority. But in other words, you can see that we have spent some considerable time preparing a response to each of those questions that may be relevant to this particular part of the NOFO. And so with that, we were going to say something, Todd.
I was just going to say, if you can go back to the slide with the scores real quick.
Yep.
So one thing, in case it wasn't clear, the areas where most of our answers are, and Conrad and Elaine, and correct me if I'm wrong, is in the 30-point implementation plan and the 30-point data storage, which is actually also reporting and monitoring. So the cut and paste answers are just coincidentally where we can help is in the places that get you the most points for your scoring. So it's about 27 pages of content to use if you go forward with using LowCode and FirstWatch and put that in your proposal. We know a lot of folks are government or have other processes that may slow down the actual contract to go forward. So the way we've described it is we're happy to provide you the cut and paste answers if you commit to putting us in your proposal. That way, if you get the proposal, then you'll go forward with contracting. But our answers wouldn't really apply to you unless you're using LowCode and FirstWatch to do the work. So it doesn't make sense to necessarily send that out, except to people that are going to put us in the proposal.
Thank you for that, Todd. We'll just go back down to and then a few slides just to kind of show you the questions or the issues that we've picked out. And in the final document, of course, we have answered in full, again, as Todd described, for you to use to cut and paste into the document as you prepare it to submit on the 11th of May. And so, again, a lot of data and QA/QI related questions. And again, we have in the full document answered these questions with a considerable amount of narrative to help you along. And I'm just sort of slowly scrolling through so you can pick out. We will make this presentation available, and as we've already said, the recording is available to watch back again as well. And obviously the funding piece, it's going to be individual to each individual organisation. As Conrad has said, some people are doing ACE, or some people are ECNS already, and obviously there needs to be a very individual construction to help you with your budget preparation. And both the folk at FirstWatch and indeed at Priority are standing by to be able to help you to construct that part of the budget narrative as well. Hopefully.
And I'll just jump in that I know that Elaine is also able to help and has a ton of the practical on the ground experience. And part of what I would say is even with the software on the LowCode and FirstWatch side of things, obviously there's a lot of work to do with actually thinking about hiring nurses and you know, setting up schedules and all the rest of the work around this. And she's done more of that than anybody that I know. So I would encourage you to consider talking with her as well.
Excellent point. And well, Elaine, I'll let you speak at the end and sort of talk about how we get in touch with you, etc. So that's the layout of the template that we've done. As I said, we've actually completed the answers, and this afternoon, once we send out the constant contact email, you can then get back in touch with us, and then we, of course, can get this stuff starting to roll out to you. There are some additional considerations that we need you to be cognizant of, and I think, Conrad, you're going to talk about those.
Thank you, Rob. You know, I think interoperability is quite important with this notice of funding opportunity. The things that you have to consider taking into account is also getting a quote from your local CAD vendor. We have a proprietary interface that we share with your CAD vendor to develop this interface, and we assist them with testing. We don't charge anything for that, but your CAD vendor will. So try and get a quote for them and accommodate for that. Same goes for the resource management directory of services. This is a vital part of this whole rollout of the medical triage line. The better your resource management or directory of services is set up and populated for alternative destinations that's available in your community, other than just the ambulance to the hospital, will make a success of your specific system and implementation. So make sure you get quotes. We will include a document from a potential vendor that's working closely with Microsoft in the community. that can assist with this directory of services. There will be a document that we will include. You might also want to budget for other features that enhances the experience, the triage experience for the nurses. There's a video conferencing capability within our software that's available. And also looking at information sharing once a triage has been completed, have the capability of sharing the call log or summary call log or any additional interim self-care instructions that was given, or links to a third-party transport providers, for example, Lyft or Uber, can be shared via text or email with the patient or a healthcare provider or a payer of their preference. And then very important, we will also work with individual customers to quote on the implementation, as we did in the past, same with FirstWatch. Yeah, that's it, Rob, from my end.
Thank you. So that brings us on to the final slide, which is the contact of the details of the folk. We'll leave this slide up for a little while. And obviously, if you need to get in touch with folk, then you've got sales at FirstWatch, info at Prior to Dispatch. There's Elaine's details. And Elaine, do you want to talk about some of the kind of wraparound services you can provide? Obviously, we spent a lot of time talking about the detail of the data, but clearly things like the staffing plan, etc., is something that we haven't considered, but of course you have a lot of experience with.
Yeah, sure. So I've worked with agencies and really closely with FirstWatch and Priority Solutions to develop their programs, set up their quality programs, and just to ensure that the safety of their callers happens. Kind of collect data. What does your community need? Because like at REMSA, we identified really areas that our community needed. And then when I've worked with other communities, of course, their needs are completely different. So just to set up your program to meet the needs of your community and just help hire nurses. That's probably the key, is to hire the right nurses and educate them and make sure that they're managing these calls correctly. I think those things I can really help with. And so thank you.
Thank you. And finally, also the other contact detail that's on the slide is we are by no means the absolute subject matter expert in all things ET3 or NOFO. And please make sure you're using the ET3 model at CMS address for any general inquiries, of course. And we know from, as Conrad has told us, that they're very responsive in getting answers out. So that is where we are right now. So let's go to Mike. Any questions, or indeed if you want to unmute, if you want to come on camera, ask any questions, ask us to go over anything you've just heard, by all means, please do so.
At this point in time, we do not have any questions in the chat, even though we have a bunch of really bright old and new friends in the circle. So any questions anybody has or comments, please unmute yourself and just speak out, or type something in the chat and I can read for you, whatever you like.
If it gets unruly with all the shy EMS folks, there's a way that you can raise your hand so that we can take you one at a time, but it doesn't seem like it's too big of a problem. We sure appreciate everybody being on, and we'll be on until the questions stop or until the top of the hour.
Hey, Conrad and team. Todd, good to see everyone. Dave Slattery from Las Vegas Fire Rescue. I was wondering if you could talk a little about, Todd, from your perspective. I have two questions. One, Todd, can you please talk about what that data looks like with your surveillance over REMSA's, the CAD, the ECNS, ProQA, ECNS, and then both the community paramedic portion and the LowCode. So specifically interested in the interface of connecting LowCode data to the rest, which is fabulous. And then the second question, more probably for Conrad or Elaine, maybe talk about agencies in terms of, I know when we started again, we're just in kind of the pilot phase still, but one of the things that was really important, I think is going to be a challenge but important information for the NOFO, for any agency that's submitting, is estimating the volume of calls and the in terms of the staffing, the timing of that staffing relevant to the community's needs based on your 911 call data. So maybe we can talk about both those things.
Cool. I'll go with your first question. So in REMS's case, we do monitor in their case, TriTech CAD data, or Central Square now CAD data, their ProQA data itself, and their LowCode data. It's a connection directly into the LowCode database, having worked with Priority Dispatch and Priority Solutions in that process that's been in place for a few years. And we are doing, for people that are familiar with FirstWatch, all the kind of normal things you could think of. But for example, looking at calls that went to the nurse and then went back to the CAD for dispatch, or even getting an address and then looking for a future ambulance call to the same address for a patient that you dealt with from a nurse health line. You maybe referred them somewhere else, and then you ended up going back in emergency mode, within a few hours later or a few days. And in their case, we also have the electronic patient care record data, so we can even see when they responded back to that patient later, what were the patient's issues, vital signs, problems, things like that. So really, there's a lot of work around linking that data together and using it to be able to track, the effectiveness and safety of the patients handed off to nurse triage, handed back from nurse triage, and followed up with as well. And then all of the normal kind of what I would say is, sort of statistics and operational issues related to, just how many calls, some of the predictive analysis that you were talking about in terms of hour a day, day of week volumes, as we go through that. The volume in most places hasn't been enough to necessarily need, say, like a full demand analysis type approach, but certainly from a hour a day, day of week patterns, a lot of flexibility there. But also time spent on calls, time spent on certain kinds of calls, completion of the call. We do a lot of free text monitoring of that underlying data as well, so you can get in, as you can imagine, as you know from your implementation there. The sort of protocols or guidelines associated with LowCode and Nurse Healthline is much broader than the 35, 36 kind of problems that we typically see in the EMS world. And so we do a lot of work on that. We have not yet had anybody implement LowCode into our first pass quality improvement tool, but I think as we move forward and have more and more customers using Nurse Healthline and ECNS data, particularly LowCode, I think we'll be seeing that as well.
So there's a question in the chat from Hazel asking if
hang on a second, Mike. I think we've still got a second part of the answer for this one. Just hold your thought.
Sorry about that.
Good morning, Dr. Slattery. Very good question. Over the last decade or so, we started gathering ProQA data from agencies, and we then map our eligible code set. So those codes that's considered safe to be sent from ProQA to the ECNS medical triage line. And we found that typically between 12 and 15 to 16% of your total call volume can be considered eligible for further triage. Does that mean that all 12 or 16% of your call volume is going to end up with the nurse? The answer is no. Reason being, if you don't staff 24/7, you're not going to get all the calls. Some of the calls come in simultaneously, and you might not have enough nurses on hand to deal with those calls as they come in. One of the requirements for this NOFO funding opportunity is that we only deal with warm handoffs, and to ensure that there's no delay should this actually turn out to be an emergency. Over the last few years, we were able to also figure out that your low acuity calls track the actual 911 call volume. So we typically see a rise from about 7, 8 o'clock a.m. in the morning, and then we see a dip later in the evening around 10 to 11 o'clock at night. And the eligible calls follows that typical pattern that we see. The CMS also does not require you to operate 24/7. You have the option to operate on your hours that you choose. We find that those hours are fairly consistent, daytime hours, and you can staff accordingly. Just some of the reports coming out of LowCode will also put a heat map, create a heat map to show at what time of day the calls came in, to better plan your staffing around those times where you might want more than one nurse, specifically being staffed at that time. This is also a collaborative agreement, funding opportunity with CMS. So obviously CMS will be quite involved. I think it's a brilliant opportunity for those existing agencies having a medical triage line to expand on the functionality and the kind of customer services aspect, making it easier for our patients out there. But it's also opportunity for those that do not have a current triage line to get that established.
Thank you.
Thank
Can
you.
you come back on that question, or over to you, Mike?
Dr. Slattery, did we answer your questions there?
Yes, thank you very much.
Absolutely, absolutely. So the question from Hazel is, anyone in Canada implementing or has implemented this program? And then John added in underneath that Niagara EMS in Ontario and Urgent Santé in Montreal, Quebec, Canada have done some things around that. Would you y'all like to comment on the Canadian versions of this?
That's correct. We started with which the then called SIAM. It's the predecessor of ECNS. Rob's very familiar. They implemented that in 2004 in the UK already. Rob's agency started with 2 seats and doing a few calls to where they now, 17 years later, 59 workstations, 80 staff, and dealing with up to 700 low acuity calls in their 909 system per day. So Canada, the guys at Niagara EMS was first to pilot the system in Canada about 4 or 5 years ago, and did comprehensive studies before they actually pulled the trigger, and is now live with the system outside of a pilot environment. We recently just completed the implementation in Urgent Santé. That went live on the 10th of March in a dual language implementation where the nurses have the option to do the call in either Canadian French or in English.
And then from our side, in the FirstWatch side, although we're not monitoring LowCode in Canada, we have a number of customers in Canada and have for decades.
Sounds good. That's all the questions that are in chat at this point. Hazel said great in response to that. I do not see any hands raised. Would anyone like to unmute and ask anything or type anything into the chat?
Mike, I just have a comment I wanted to make. The way that we attempted to answer these draft template answers to the questions was taking into consideration the fact that some agencies will be new implementers, whilst others will be expanding on their existing implementation. We don't know, we don't have intimate knowledge of their local settings, resources that's available. But just take these templates and build out on it with your local knowledge. One of the questions on sustainability, it's quite a few points, it's 25 points. Look around, see what's available in your community as far as the ongoing funding after year 2 of this program. You would want to reach out to hospital systems, third-party payer systems in your community, and also look at state initiatives. I'm acutely aware that in Colorado at the moment, there is a funding opportunity for a medical triage line parallel to this opportunity. So take all of those into consideration when you look at the sustainability question and answer on the NOFO.
Well, Conrad, I'd like to add to that. I think really thinking outside the box when you're trying to figure out how this is going to work in your community. I think that with ACE accredited centers, you have a lot of options on how to roll this out in your community. And I think looking at, honestly, the Confire model for staffing, they were not able to staff their nurse triage center during the hours of the highest call volume, where they had long wait times in their emergency room. So the nurses at REMSA are licensed both in California and Nevada. And so we were able to do that partnership, which has never been done before and was very innovative. So I think when you're trying to figure out how to roll this out, think very outside the box, what's available in your community and how you can roll this out the best way to meet your customers' needs.
One other comment also with regards to the implementation, we will also send a PDF document outlining the 6 implementation phases during a new implementation of a medical triage line.
Yeah, I think it's safe to say that, we do have some things that we can sell and help you, but I think our original motivation for this was we've responded to proposals like this a lot in the past, and it's a lot of work. It's a very short timeline. And even frankly, as Conrad mentioned at the beginning of this, the NOFO's, discussion of, creating protocols and doing all this stuff. What I would tell you, having been part of the REMSA process and implementation, 2 years is not enough to create a system, or I think modify a system that's not used for this particular kind of work. That's just my personal advice or thoughts. And I think if you want to participate, there's going to be a lot of things that you have to work on that will be new for you and your system. I would just suggest that you consider not having everything be unproven, and knowing that LowCode and the FirstWatch and the EMK-Consultants kind of approach is really what was developed from not only decades of work, as Conrad pointed out, on the LowCode side and the FirstWatch side, but particularly in the implementation with Elaine's expertise. There's a lot of this that you don't have to wonder about while there still is a lot of work to be done on your side that most places haven't done before. So I think we can help you. I think it'll make some sense, and we just encourage you to take a look at it, because creating it from scratch or creating it from modifying some other nurse healthline approach would be a really daunting task. Thank you all very much. We really appreciate you, and you guys did a nice job, Conrad and Elaine, Rob.
Thank you. So just to recap, the contact details are on the screen still. This afternoon, once we've had a chance just to get our next conversations that matter out of the way, which is literally butting right up against this show, and Mike's getting ready to do that. We will then send out a constant contact email with the detail in, and then from there, then you can then reach back, and then we will send you the completed templates as we described and discussed today. So I'll just, I guess I'll give any final thoughts, Conrad, Elaine, and Todd. Go with Conrad first.
Thank you, Rob. Thanks again for the opportunity. I think it's not often that opportunity like this comes by where somebody else is funding a startup of a medical triage line or can expand on the current functionality. Just reading through the NOFO, it's clear that CMS and CMMI has done their homework. They touched on all the important aspects of a line like that. What I do want to point out is safety. We must make sure whoever's protocols you're using, just make sure there's safety elements built into it, checks and balances, so that we can do this for many years to come and impact our patients' lives out there positively.
Thank you. Elaine?
Yeah, thank you for the opportunity to present. I also think I agree with Conrad. I think there's a lot of different opportunities to partner with, but I've done a little research on them myself and feel like I've worked with these protocols for 10 years now and have not seen any bad outcomes in the agencies that I've worked with, to be honest. And at REMSA, we were managing about 2,500 calls per month during our grant time. And some of those were 7-digit calls because we did develop a direct line in for callers. They were not all alphas and omegas, but I really learned to trust the protocols and the process and then the data that FirstWatch is able to get for us. So thank you.
Thank you. And Todd.
Well, I have nothing more to say other than thanks very much. I really appreciate everybody spending the time. Good luck with what you're doing. Hope today is quiet and peaceful in your community with everything going on in Minnesota. I'll also, if you're just bored in the next couple of hours and want to spend some time listening to us talk about engagement and have some experts do that, I'm going to paste into the chat a link to that. We're doing a Pinnacle oriented webinar that's very much also like our Conversations That Matter, starting in, I think, about a half hour or so, maybe 45 minutes.
And Malachi asked a quick question about, will a link of the recorded webinar be included in the constant contact email this afternoon? I think the recording takes a little while longer than that to post. So there will be a link to the recording, but it might not make it out this afternoon. It may be tomorrow.
Depends how long it takes to cook, but it'll definitely be there.
Exactly.
Okay, well, we hope to hear from you all very, very soon. Obviously, as you've heard, everybody is here to help and to assist. And I think with that, we'll leave it there, and we look forward to hearing from you soon. So thank you all for coming, and see you all later.
Thank you,
Thanks,
Rob.
folks.
Thank you all.
Bye.
All right, see everybody.